This is going to be the supplemental lecture for Chapter 6, which is the General Coding Guidelines for Procedures in ICD-9-CM. So, the only things that you really need to remember about the format of Volume 3 is that it is very similar to the format and the conventions that you find in the Volumes 1 and 2 of the coding manual, which cover the diagnosis codes. There are 17 chapters, and what you do need to remember is that these procedure codes are used for inpatient, hospital inpatient encounters. We don't use them in an outpatient setting such as a physician's office, okay? You can find them under a common, if you have a procedure, you can find it under the common name of that procedure. But you are going to have to kind of flip your thinking to understanding that when we are looking for a diagnosis code, our main term is going to be a noun. When we are looking for a procedure code, your main term is going to be a verb, most likely, such as insertion, incision, excision, clipping. Those are all verbs. Those are all things that you do. All right? Now, you could find them under an eponym, and remember we said an eponym was when something was named after a person. You may find things such as Whipple procedure, etc. Okay? So, that would be the common name of a procedure. If you don't know that, then you can look for that verb. Okay? All right, so in the alphabetic index, we do have a few things. We have something called omit code that you will see. It's an instructional note. It's used to code approaches. So if you are coding an approach that could be a standalone procedure, it could be a standalone procedure, but it's the only way to perform another procedure. They need to get to that particular area using a scope of some kind or whatnot, and it's considered an integral part of the procedure, you will see the note that says omit code. You don't code for that procedure as you would if it were standalone. So for instance, if you had, let's see, if you had a procedure that was typically done through use of a scope. It was typically done through use of an endoscope, but you were going to perform something called a Rose procedure on a bariatric patient. That Rose procedure is done using a scope. You don't code the scope. You do not code that. However, if you were doing a scope on its own, you would code it. All right? That's when you'll see omit code. Code also is just that. Code an additional procedure. That's just like the diagnosis instructional note to code also. An adjunct code is one that you have to add on to a procedure to provide more information about what you were actually doing and what that primary procedure is. Those codes cannot stand alone. And if you look in your book on page 121, there is an example at the bottom of the page, and what it says is percutaneous transluminal coronary angioplasty, or PTCA, is performed with a drug-eluting stent placement into the LAD for coronary atherosclerosis. Now, all of those little codes that you see, 00.66, 36.07, 00.45, 00.40, those are adjunct codes. They give more information about what did we do once we got in there with the PTCA. All right? Again, remember, they cannot be standalone codes. You must have a primary procedure to code along with them. Okay? So let's talk about what a principal procedure is. So just like we have the diagnosis for a principal just like we have the definition for a principal diagnosis, we have a definition for a principal procedure, and that is one that's performed for a definitive treatment instead of diagnostic or exploratory purposes, or it's one that was necessary to take care of a complication. All right. A significant procedure would be the equivalent of, say, your secondary reportable diagnoses codes, okay? So when we have a secondary significant procedure that we need to report, it has to meet one of the following criteria. Is it surgical in nature? Do we have to take them into the OR room? Do we have to do that? Does it carry a procedural risk? Is there a risk that perhaps we could, you know, it's in very close quarters and perhaps we could nick something, or perhaps we could miss something? It carries a procedural risk. Carries an anesthetic risk. Is there a risk that you could stop breathing from anesthesia? Is there a risk that you could lose feeling in your arm if you're having a nerve block? And does it require specialized training, such as when we are doing PTCAs and we're going in and doing that cardiac catheterization? That requires specialized training. So it has to meet one of those four things, okay? Not all of them, just one, okay? Where can you look for some of these things to make sure you don't miss anything? Well, look in your consents. Remember, every patient has to have an informed consent, and you've learned about this in your other classes, for a procedure. And that has to go into the record before the procedure takes place. So look for those, all right? But keep in mind, just because you find a consent doesn't mean that the procedure was actually performed. Anything could happen. It could have been canceled for any reason. The patient could have backed out. It could have been anything. So when you find a consent, you need to look for that documentation to support that that procedure was done. It's just a starting place for you, okay? Remember that a procedure does not have to be performed in an OR. It could be a treatment room, it could be bedside, it could be in an interventional radiology room, it could be anywhere, okay? Also, as you're coding these, you will have to abstract out the date of the procedure and the physician that performed it and enter that in as well. So, oh, excuse me. Keep that in mind as you're going through and coding, all right? Okay, we do have a couple of special guidelines when we're talking about procedures, and we're going to talk about those real quickly. They are the OB principal diagnosis selection, debridements, and V codes. And let's talk about the OB principal diagnosis, or first listed diagnosis. So there are some guidelines that we follow, okay? And I want you to, if you can, turn to page 123 in your book, your textbook. And at the top of the page, you will see the first blue box that talks about the guideline, all right? When you have an episode of care where absolutely no delivery takes place, okay, then the reason for the encounter is going to be the principal diagnosis. So the example they give you is vomiting due to mild hyperemesis gravidarum. So patient's 10 weeks pregnant. They're just really, really, really sick with morning sickness, terribly ill, all right? But at 10 weeks, obviously, they're not going to deliver. So the principal diagnosis is going to be the vomiting, all right? It's going to be the hyperemesis gravidarum. So let's say a vaginal delivery occurs. The principal diagnosis needs to correspond with the circumstances or the complication of the delivery. So what does that mean? Well, if we look at the example, patient at term, 40 weeks with obstructed labor due to breech position, lower segment cesarean section was performed with the delivery of a single live-born infant. Now, just a side note for this particular one, I did do a Snagit video on how to find these particular codes. Where do you look in the index? How do you get to them? Okay, so I did do that for you, and it is a separate video. It's out there on the YouTube channel. Okay, so why did this patient actually come in? She came in for the obstructed labor. She did not come in because she came in for the labor. but she did not come in, she came in expecting to have a vaginal delivery, but she needed to have a cesarean delivery, okay? When that happens, the reason for the cesarean delivery becomes your principal diagnosis. So, because she was having obstructed labor, that is the complication that she's experiencing. That is going to be the principal diagnosis. That code is 660.01. That will be followed by what is causing that obstructed labor, the breech, 652.21. That will be the delivery of a breech child. So she had obstructed labor with the delivery of a breech child. Then, of course, you're going to have your outcome of delivery code, all right? The only exception to this will be if a patient comes in, say a patient comes in and she's 32 weeks pregnant, and she's been in a terrible car accident, terrible, horrible car accident, and they have to put her in the hospital for the trauma. And while she's in for a few weeks, and she goes into labor, and she delivers her child by cesarean section. Okay, they have to go in and deliver the child by C-section. That will, or it could be vaginal, but that will not, that will be a secondary diagnosis code, the delivery. The reason that she was admitted was for the trauma. That is the reason for her encounter. That is her principal diagnosis. So you need to remember that. So if there's a cesarean delivery on a patient, typically it will be the reason that the patient is having the C-section, obstructed labor, okay? Unless they're admitted for a reason that's unrelated to the pregnancy, okay? Debridements. We've talked a little bit about debridements.
Powering on.
Oh, there goes my speaker. We've talked about debridements in class, right? Okay. So, a debridement is where you go in and you do what? You get rid of all that dead necrotic tissue, right? All that yucky stuff goes away, correct? All right. So, when you have a patient that's having a debridement, make sure that you don't stop at reviewing the physician documentation. You need to look for physical therapy documentation, or wound care specialist documentation, because those individuals are capable of doing debridements as well, as long as they have been specially trained. Again, it goes back to that specially trained. Specialized training is part of that significant procedures, correct? So, look at those terms that you see. You will see two terms, excisional and non-excisional. Excisional means that it is surgical in nature and they're cutting things away. Non-excisional means they're doing brushing with a brush, they're scrubbing something, they are washing, they're doing something else besides cutting the tissue away, all right? It's very important that when you have excisional, when you code excisional debridement, you must have excisional mentioned somewhere. You must have use of a scalpel mentioned somewhere. Scissors are not sufficient to code excisional debridement. Keep that in mind, okay? So when we are coding an excisional debridement, we are going to code it to the deepest layer that we have to debride. So if you have a patient where all you have to do is debride the top layer of skin, you'll just do that skin and subcutaneous tissue code. However, if you have someone that you have to go down into the muscle tissue and debride, then the code that you would put on is muscle. If you have to go to bone, the code you will put on is a bone, down to the bone. Now, the reason you do not put the others is because in order to get to the bone, you have to go through soft tissue and muscle, right? And chances are, if you are doing a bone debridement, there may not be a lot of soft tissue and muscle or subcutaneous tissue and muscle there, because it may have already become necrotic and had been debrided at some other point. Keep in mind, you go to the deepest layer of debridement. So as far down as you go, that's where you code to. Okay? Let's see, where are we? If you're debriding something as part of another procedure, so you have to debride some tissue to get to, let's say you get into get to a patient and you've got to do some type of a procedure that involves you having to get rid of that dead tissue. You don't code that separately. You do not code a debridement separately in that instance, okay? So, V codes. We've talked about V codes now. V codes are what? They classify factors influencing our health status. So our history codes, our personal history codes, our family history codes, status post codes, our exposure to communicable diseases, those codes, etc. Okay? And they also denote contact with health service. So an encounter for whether it be a prophylactic move, a vaccination, an examination, a screening code. We're screening for something, right? A contact with health service. Keep in mind, they're not procedure codes, and we have to pair them with a procedure code. They are diagnosis codes. So we've talked about those now in class. Procedures that you have to report and that you should report. So you might see lots and lots of procedures there and not really know what you should report and what you shouldn't. So the procedures you're going to report are those that are going to affect payment or reimbursement. And we will learn about those as we go through. Okay? We'll learn about those. You will get... how do you know if it's going to be paid? How do you know if it's going to be reimbursed? You will get information as you go through that, little edits, little tips and tricks and things that you will see when we start to use the encoder in a few weeks. And in your book, those types of things, you will... you'll see those little tips and tricks, okay? Other procedures that your facility says, hey, we want to track this, so you need to code it for us so that we can pull the reports, right? So different procedures are recorded in different places. So for instance, Port Huron Hospital may record some type of a CT scan. Mercy Hospital may not, okay? You need to make sure that your coding matches. The procedure codes that you have, you need to make sure that they are supported by a diagnosis code. Okay? That's very important. Your medical necessity codes, those are things that say, your medical necessity. That is where you say, where you must have documentation to support a procedure being done. So that's different from the diagnosis. Because the diagnosis, they could just write the diagnosis down. A medical necessity, you need to look for the clinical things that they did to that patient. Now, it stands to reason that if you look for those clinical things, you will have already gotten the diagnosis code that support that, correct? So they kind of go hand in hand, matching your coding and your medical necessity, all right? A valid OR procedure, all right? These seem a little confusing to people, just because they're kind of strangely worded, and well, if it's an OR, it must be valid, right? Well, a valid OR procedure is one that is recognized by the MSDRG grouper as an OR procedure. Okay, it may affect the reimbursement. And it's one that's done in the OR. But do not confuse that with being always an inpatient, because we can go into the OR as an outpatient, correct? So don't confuse that. All right, we have a lot of outpatient surgeries that we perform that we used to perform inpatient. Hernia repairs, arthroscopic knee surgeries perhaps, different things that we used to perform inpatient only, but we know now that they're safe to perform outpatient. But they're still performed in an OR, therefore they are still a valid OR procedure and they may still affect the DRG. Okay. A non-OR procedure that may affect the DRG assignment are ones that they're not always performed in an OR. They're not always taken back to that green and white room. They're not a tiled room. They're not always back there. All right. They could be done in a treatment room. They could be done bedside. They could be done just about anywhere. For instance, excisional debridement can be done bedside or in a treatment room, and that does affect your DRG assignment. 86.3 does affect your DRG assignment. All right. Let's say you have an OR procedure that you would typically do outpatient or maybe not in an OR. Could be a cath lab, could be interventional radiology, nuclear medicine, all right? You may admit the patient following the procedure, and some of those factors might be age, young and old, both. If they have another comorbidity, such as diabetes or a heart condition, okay? And the MSDRG with that may be changed from medical to surgical, and that surgical is going to give you more higher reimbursement rate. So you need to make sure you have all your documentation to support that before you do it. All right. A non-covered OR procedure is just what it says. It's a non-covered OR procedure. It's not, Medicare will not reimburse it. You will get little notes, the Medicare code editor, or the MCE. You will see those little notes and little edits pop up when you are using an encoder. They're typically ones that Medicare has deemed not medically necessary. They're really not necessary to do, even with a diagnosis, an appropriate diagnosis to support it. Or it could be one that you performed inpatient, but they consider it an outpatient. All right, so this is an instance of, don't think just because you have Medicare you're going to have insurance covering everything, okay? Limited coverage. So limited coverage means sometimes it's covered, sometimes it's not, and there are specific guidelines that are in the Federal Register for each one that you have to meet, period. That's it. It's very limited. They'll cover it sometimes, but sometimes they won't, okay? Surgical hierarchy. Now, surgical hierarchy, what that means is that's when we pick out the most resource-intensive procedure. It may group that procedure, the MSDRG group may group that procedure as principal, and then it will affect the DRG code. Now, you still have to have your principal diagnosis. Still needs to be the one that is for a definitive reason, not just diagnostic, if you have one, or for a complication. But resource intensive means what's using the most resources up. What's costing us the most? Do we have to have extra round-the-clock care? Do we have to have, are they in surgery, for 10 hours as opposed to 4 hours, okay? So that's what surgical hierarchy means. It has to do with determining that DRG. Computer-assisted surgery is just that. We utilize a computer to help us see. We're still doing the work with our actual hands, but we use a computer that helps us see things better. Okay, it can get close up, it can enhance it. All right. Robotic assisted surgery is where we're actually using robotic arms, and instead the physician, it almost kind of looks like a game console. There's joysticks, and the physician is operating those robotic arms using a joystick. Okay? The computer-assisted surgery, the physician has to be in the room. The robotic-assisted surgery, the physician could be across the country, across the globe, in space. The patient could be in space. The physician could be on Earth. So it's really quite a unique thing to do that robotic-assisted surgery. It's excellent. It's a great piece of technology. It's amazing. Biopsies. So what's a biopsy? It's when we remove the tissue, right? We take a tissue sample. We can perform them in many different ways. They can be aspiration, where we suck it into we suck it out. Could be typically aspiration, we use a syringe and a needle and we pull that out. That is not the same as core needle. Endoscopic, brush, there are lots and lots of different types of biopsies, and we'll get into those as we move forward. If your tissue is entirely excised or entirely taken out, then it's not a biopsy. So let's say you go in for a liver biopsy. They take part of an entire lobe. They take an entire lobe of your liver. That's not a biopsy at that point. That's a lobectomy, okay? All right, endoscopic approaches. That's where we're going to look in a body cavity using a great big long tube with scope on the end of it, camera on the end. We're going to take a peek, okay? We're looking around. Now, if we're only going to look around, then we code the destination and not the journey. What does that mean? That means if we're going to go in and we're going to do an esophagogastroduodenoscopy or an EGD, and we're going to look at the stomach, we're going to code to the stomach. We're going to code the destination, not the journey. We're not coding how we got there. Did we get there by bus? Did we get there by train? Did we get there by car? Did we fly? We're not coding that. We're coding that we got to the Florida Keys. We're going to code the Florida Keys. Does that help? I'm hoping. If a procedure is actually performed, then we code the procedure. A biopsy, replacement, right? If we go in to do something. An endoscope at this point is the approach, so try to keep that in mind, okay? Operative approaches and closures. So look for that omit code in these instances, because that's where you're going to see them, approaches and closures. So you don't code sutures. You don't code certain things. That's where you're going to see that omit code. For instance, otomies, laparotomies, those are actual incisions, but they might be part of that operation. Okay, so you need to look for those omit codes, instructions, all right? You're going to have to read the entire report. When you see exploratory, you need to keep in mind that exploring in there is usually a component of most surgeries. That's usually something you do. You go in, you explore, and you look around, right? So that's typically very common. So don't necessarily jump right to coding that exploratory, okay? Closures. If you go in for surgery and let's say we go in and do a colectomy. We do a hemicolectomy. And while we're in there, we remove what we need to remove, and we put in the we put in a stoma, we do an anastomosis, and we close you up, send you to the recovery room. Okay. In that instance, we don't code that closure. We don't code those sutures in that closure. However, let's say The same patient went in for a hemicolectomy, and while the patient was there, something happened, and the bowel became very inflamed, swelled up, and they couldn't pack it back in. In that instance, they may not close the patient at that point. They may put some protective coatings over top and leave the patient open until that swelling goes down in the bowel, and then they take the patient back in a few days later and close. If that happens, then the closure is coded. You do code it if you have to go in after the fact. All right? Okay. So what happens if you have a procedure that starts out as what we call closed, and then we have to convert it to open? So a lot of procedures that we're doing now, we're trying to do with scopes. We're trying to do them because it's minimally invasive. It's safe for the patient. It can save money, right? Because patients don't have to be in the hospital as long, or maybe not at all. They are more time consuming for the physician. However, it's just better all around for the patient, and that's the bottom line, right? Okay. So let's say we have a procedure that becomes open. So for instance, a patient comes in for a laparoscopic appendix removal. Laparoscopic appendectomy. But when they get in there, everything is such a hot mess, and so there are adhesions, and it's so bad. They find that it is actually burst. It's ruptured. Okay. In that instance, they need to open the patient up. They've decided they need to open that patient because they've got to make sure they get everything, because they don't want the patient to develop a peritonitis. All right. So what happens in that instance is we code a V code. There is a V code that is used, all right, that lets us know that we've converted from an open, that we started out open, and we have converted to a, we started out closed and we converted to open. Those V codes, there are 3 of them. They are V64.41, which is laparoscopic surgical procedure converted to an open procedure. V64.42, which is thoracoscopic, excuse me, I'm having trouble talking today, surgical procedure converted to open procedure. And V64.43, arthroscopic surgical procedure converted to open procedure. Now, keep in mind, that is a diagnosis code. So if you have a situation where a physician has converted from closed to open, automatically think to yourself, I need to slap the diagnosis V code on there to let them know we started it open and started it closed and we finished open. All right. That will let them know. Now let's look at I think the best way to deal with this is the examples. So let's look on page 130 at the very bottom of the page. And what does it say? Patient was admitted for a laparoscopic cholecystectomy for chronic cholecystitis with cholelithiasis. Because of excessive bleeding from the liver bed, the procedure was converted to an open cholecystectomy, and the bleeding was controlled. All right. So if you look, there's our V64.41 code, correct? Laparoscopic surgical procedure converted to an open procedure. Okay. And then if you look, we have code 51.22. What is 51.22? Let's take a peek. I'm going to grab my book here and just read that to you. 51.22 says cholecystectomy, period. That's it. Now, there is an excludes notes that says excludes laparoscopic cholecystectomy right underneath it. So make sure. So we are not going to code what? We're not coding that laparoscopic procedure, but we do put on there that's why it's so important to have that V code there, because that's saying, hey, we did start it laparoscopically, but we had to switch over. Okay, check with your facility. They may have a special policy as to how they code those. So that would be one that you would want to maybe ask about. Okay. Bilateral procedures. Bilateral procedures are just that. They're ones that take place on both sides or both hands or both legs. Those are, and it's the exact same procedure on the exact same body part. All right. You'll need to look for things like bilateral or unilateral. You'll see this a lot with hernias. Lots and lots and lots, particularly with inguinal hernias. You will see a lot of those things, okay? You'll see tons. So, in fact, in your book on page 131, one of your examples is open repair of bilateral direct and indirect inguinal hernia with synthetic prosthesis. All right, so when you're in there, you need to look. Check your procedure codes. Read very, very carefully, because you will have some instances where you will have a code that will cover bilateral, but in other instances you won't. And if you have an instance where it does not cover bilateral and the code doesn't say bilateral, then you need to code it twice. So look at your second example on page 131. Primary osteoarthritis, knees for bilateral total knee synthetic substitute replacement. Okay, the diagnosis code is there. However, if you look at the procedure codes, we have 81.54 and then we have 81.54 again, because that code, there is no code to encompass the bilateral aspect. So in that instance, we have to put that code on there twice. All right. All right, so what do you do if you have somebody that there's a planned procedure, canceled procedures, you know, you have somebody who wants to come in for, oh, I don't know, they're coming in for a facelift. Mrs. Richbody, hello, she's coming in for her facelift. Okay, so she's going to get pulled tight again. So she plans that, right? That's not an emergency surgery. It's a planned elective surgery. Sometimes they back out. Sometimes they just don't show up. Sometimes they just don't want to be there. They decide they don't want to have it. Okay? They say, I'm not coming in. When there is that instance, no record is going to be generated because they're not actually there, right? Nothing is done to them. Now, a cancellation is a little bit different. Sometimes a patient comes in and maybe we can't do the procedure for a clinical reason. Maybe the patient comes in and their blood pressure is so sky high, it's not safe to put them under anesthesia. Maybe they've eaten. Perhaps the patient has eaten breakfast when they were told not to. Okay? So in that instance, your principal diagnosis is still going to be the reason the patient was going to have the procedure. So Mrs. Richbody comes in and she hadn't really listened or paid attention to what her physician said, and she ate breakfast before her procedure, 2 hours before. So in that instance, we have to cancel Mrs. Richbody's procedure, but we're still going to put the reason she was coming in to have the facelift in the first place as the principal diagnosis. Then for our secondary diagnoses, we will put the reason, the clinical reason for the cancellation, and then we will we'll follow that up with the V code for cancellation. We're going to talk about those in a minute, but let's go back to the clinical reason for the cancellation. Let's say Mrs. Richbody couldn't have the procedure because her blood pressure was so high. In that instance, the clinical reason is going to be her blood pressure being high. Okay? And her V code, if you look on the bottom of page 131, let's look at the V codes now. We have V code, we have V64.1, surgical or other procedure not carried out because of contraindication, a medical reason to delay the procedure. So a contraindication is that medical thing. So she comes in, her blood pressure is too high. We put the reason she was having the facelift. She was old. She looked old. The clinical reason for that we're canceling her elevated blood pressure, and then V64.1. We've coded her chart. Let's look at the next V code at the bottom of the page. V64.2, surgical or other procedure not carried out because of patient's decision. All right, so that would be where Mrs. Richbody decided to eat breakfast. Maybe she decided she didn't want to do it. She wanted to go shopping at Saks Fifth Avenue or Bergdorf's instead, Barney's. Okay, so she's off shopping instead. That's going to be the code that you put on the V code. The third V code is V64.3, procedure not carried out for other reasons. So those other reasons are things like perhaps the pipes froze in the OR, in 2 of the ORs, and they're very tight, and they've had to cancel all elective procedures because they need to do the procedures that are not elective, and they've lost 2 ORs. Okay, perhaps there is a case of the white flu, which is like the blue flu for police, only for nurses. Maybe the nurses are all sick, but they're actually striking. We can't do procedures because we don't have any nursing staff. Perhaps we're doing a specialized procedure that involves some very special equipment, and the equipment has malfunctioned in some way, shape, or form. In that instance, we're going to put V64.3 down. Okay, so you'll have to look and see, why are we canceling these? You can't just say, oh, it was canceled. You got to look and see why. Okay. An incomplete procedure is different from a canceled procedure. Okay, they are different. So this is when, for whatever reason, a procedure is started and it has to be stopped. It cannot be completed. Okay, so patient gets anesthesia, they start the surgical procedure, and they've got to stop. So let's look at your book on page 132, and the 4th purple box down. And the example says, a patient was admitted for colon resection because of cancer of the descending colon. A laparotomy incision through subcutaneous tissue and fascia were made, and the patient became unstable with atrial fibrillation. So they've already started, they've already cut into the patient, they've had anesthesia, they've cut into them. It was decided that the procedure should be terminated and the patient transferred to the ICU for further management. The incision was closed before any definitive surgery could be performed. That is going to be an instance where you do that, where you have an incomplete procedure. Now, how do you code those? You code them to the extent that the procedure was completed. So you will have to very carefully read through the OR report and code out to the extent that they completed the procedure before they decided to close up and abort. Okay, there are no V codes, so don't put any of these. Don't put the V64.1, .2, or .3 codes on there because they're not appropriate. All right. Check for your facility policies for all of your procedures, because they're all going to have different reasons to capture different information. So you may have, like I said, Port Huron Hospital may capture one thing, Mercy Hospital may not capture it. Okay, so you'll have to watch. A big one that you need to watch for is, it's really up and coming, is interventional radiology. So make sure you don't miss those, and check your consents. Look for your informed consents and look for a procedure to match it up. Document it in the record. All right. So that is it, and I will see you soon.